Hey everybody, welcome back. We're going to cover chapter 15 today, which is general anesthesia, which was created in 1846. All right. All right, just a bit of an introduction to begin with. General anesthesia is actually the systemic state of anesthesia. It interferes with the brain's ability to interpret pain impulses. The decision to use general anesthesia is usually based on both the surgical procedure being performed and the individual patient. Not everybody is the greatest candidate for general anesthesia. Early agents were extremely toxic to the patient, or they were explosive. There's a great insight, 15.1 on page 204, that has a little bit of a history of anesthesia. It's a pretty good read. Yes, we were using explosive agents on patients. The end goal is to have the patient awake, alert, and breathing on their own when they go to the post-anesthesia care or PACU. Okay, there are 4 goals or components of general anesthesia. Those are amnesia, analgesia, muscle relaxation, and unconsciousness. Balanced anesthesia refers to using both inhalants and IV agents to accomplish that wanted level of general anesthesia. All right, moving on to the phases. There are 5 phases of anesthesia. In order, they are pre-induction, induction, maintenance, emergence, and recovery. These are not to be confused with the stages of anesthesia. Those were based on the use of ether, so you will not hear stages of anesthesia anymore. They are referred to as phases, and there is an insight on that as well on the history of the stages and using ether on page 205. Okay, so we'll talk a little bit about the phases here, starting with our first one, the pre-induction phase. Excuse me. This begins as the patient is admitted to the pre-op area, and it continues up to the point of the administration of the actual anesthetic agents in the OR. So the patient is assessed and prepared for anesthesia and surgery. The airway is assessed. Even if general anesthesia is not being provided, we will always, the anesthesia care provider will always check the patient's airway as well, because you never know what's going to happen. So they're going to look at their neck mobility and the structure of their throat and their vocal cords, and just how well they would take general anesthesia if that need were to come up. They do use a couple of different scores and scales for those. One is the Mallampati score, which assesses the patient's mouth, their hard palate, uvula, those things. And then we have the Cormack-Lehane score, which is used to determine the difficulty level of the patient's airway if they were to need to be tubed. And medications in pre-induction are ordered by the anesthesia care, whether they need some sedatives or anti-anxieties or anything like that. Those can be given preoperatively as well in pre-induction. So here's a good example of what they're going to check for. Here on the top, we're checking neck mobility. In the middle here, this is that Mallampati score. So as you can see, class 1, they can stick their tongue all the way out. We can see the hard and soft palates both. We can see the uvula. There's just a clear view to the back of the throat. With class 2, 3, and 4, as they go up successively, you can see where that view gets more and more obstructive. And on the bottom, we have the Cormack-Lehane score. And this is the score for their airway itself. So here we're looking at the epiglottis. We can see a clear view of the vocal cords. In between here is where our ET tube would go for breathing. And so as you can see too, as those go up in score, the airway gets more closed off and difficult to view. Okay, a little bit more on the pre-induction phase. This phase continues as the patient's transported to the OR and as they're transferred to the OR table. Once they're in the OR, the circulator, and on the table, the circulator is going to secure their safety belt first, and then they're going to supply that patient with some warm blankets. As we've covered in the past, hypothermia is a very real thing in the OR. It is extremely cold in there, so the circulator is going to make sure that she gets those blankets to keep that body temperature normal. Anesthesia is going to obtain the baseline vital signs by hooking them up to those leads on the EKG, the blood pressure cuff, their pulse oximeter, their temperature, if that's what we're doing with the strip across the forehead. He's going to get a baseline level of vitals. Once all of that is complete, the anesthesia mask is placed over the patient's nose and mouth, and they are given 100% oxygen. This is called pre-oxygenation. Usually they pre-oxygenate for anywhere for 2 to 5 minutes, sometimes longer, depending on the patient. But that's performed to bring those O2 sat levels in the blood as high as possible. So that is in fact straight oxygen that's coming through the mask. Okay, once that's done, we're going to move into the induction phase. This begins when medication is administered to begin the general anesthesia, and it ends when an adequate level of anesthesia is reached and the airway is secured. So induction agents are usually administered IV. Pediatrics are an exception. They may be given a masked induction with some of those volatile agents that they can inhale, just to avoid the emotional trauma of having to get stuck with an IV and pokes and prods and hurting things. A lot of times we'll mask those little guys until they get to sleep, and then we'll start their IV afterwards. Okay, once a patient is unconscious, the anesthesia care provider ensures the adequate airway is maintained. All right, respiration is a vital function that must be maintained through the procedure. Various methods are used to ensure the airway is supported in an unconscious patient. We have the mask for short procedures with no muscle relaxation, such as a laryngotomy where we're putting tubes in. We also have nasal and pharyngeal airways that can be placed to displace the tongue and facilitate air exchange. And we have the mask secured with straps, and the anesthesia care provider can maintain a chin lift position so that patient is still kind of breathing on their own. Right, we have the laryngeal masked airway, also called an LMA or a supraglottic airway. Most commonly you will hear them called LMAs. These have a flexible shaft that's attached to a silicone base that is inflated to seal the airway. It's sized 1 through 5, depending on patient weight. It's been positioned in the laryngopharynx to cover up the epiglottis and the larynx. The cuff is inflated and the tube is attached to the breathing circuit. Patient may breathe on their own, or they might have some manual automatic ventilation with the help of the ACP and the machine. There are some contraindications to this. Obviously, oral cavity procedures, we can't have that big LMA cuff sitting in their mouth if we're working in there. Obesity, hiatal hernias, GERD, and low pulmonary compliance are also some contraindications for this. So over here is what an LMA looks like. Here we can see that very flexible shaft and that silicone cuff. This one looks like it's already been inflated. On this end here is where it would attach to the breathing circuit and feed over to the anesthesia machine. And here's where we would put a syringe, usually a 20 milliliter, to inflate this cup with air. And this is what it looks like then when it's in the patient. It goes in through the mouth, behind the tongue, and sits right on top of the larynx and epiglottis. All right, moving on through airway management, we also have endotracheal tubes. You will hear them called ET tubes. These are used when levels of deep muscle relaxation is needed, especially when the patient is prone or lateral, or the procedure is going to be a few hours long. It's placed in the patient's trachea right down to the bifurcation into the lungs, and respirations are controlled by mechanical ventilation on the machine. These are clear, flexible polyvinyl chloride. That's what they're made of. They're sized by internal diameter in increments of 0.5. So we have, 0.5, 1.5, 2, 2.5, and up to, I believe, size 8. They're placed through the patient's mouth into the trachea for the most precise airway. And the placement of the tube is called intubation and is done after induction agents and muscle relaxants have been administered. That way our patient is unconscious and immobile, so they won't be aware and they won't fight us trying to put that tube in. Laryngoscopes are used to retract the tongue and lift the jaw, and to visualize the larynx and vocal cords. The ET tube is inserted through the cords and into the trachea. We also have video laryngoscopy available for those difficult airways, such as on that Lehan score where we saw that the epiglottis and vocal cords were not visible. We can use this. It allows for tube placement with the patient's head in a neutral position as well for those that have neck problems and they're not very mobile in their neck area. And that is referred to as a glide scope, most commonly is what you will hear that video called. So over here is an example of an ET tube. As you can see, it's also very flexible. It does have markings on the outside in centimeters, and that lets us know how deep we are. Again, this end is going to be attached to the breathing circuit that feeds to the machine. This is where we are going to have our syringe to inflate this cuff that helps hold the ET tube in place. And this is what it looks like once it's in. As you can see, it goes straight into the trachea. All right, over here is a laryngoscope. They come in two different blades, Mack and Miller. Some are curved and some are straight. And you can see they do have a light here for visualization. And over here is an example of that glide scope that I spoke about a minute ago that helps us. This will pop up on a screen, this vision, or this image, and it helps us guide the tube straight in. So as you can see here, we're using that. Here's our laryngoscope with a Macintosh blade. It's a video cord as well. And you can see their epiglottis and their vocal cords are obviously very difficult to visualize with the naked eye. That's why we're using this screen. So when the tube goes in here, you can see a direct line of vision to get that into that difficult airway. All right, next we have a rapid sequence induction. This is used for patients that are at risk for gastric reflux and pulmonary aspiration. For example, patients that have not been NPO, such as our emergency patients that may not, they may have had a full dinner and then something has happened and now they're in surgery. Obese patients, hiatal hernias are very prone to gastric reflux, GERD obviously, diabetes, and sometimes those that have had previous GI surgeries will also be at risk for a gastric reflux. So when we do a rapid sequence, the patient is pre-oxygenated, and a dose of both pancuronium and succinylcholine are given. These are muscle relaxants. Okay, cricoid pressure is applied to prevent gastric contents from entering the trachea at the lungs, and then it's maintained until the ET tube is in place and that cuff is secured. An NG tube, nasogastric tube, may also be placed through the mouth once that ET tube is in place. And that's a sort of suction that will flow down into the stomach, and then we can empty out those stomach contents by suction. All right, some other intubation techniques might be used in certain circumstances, such as a nasal intubation or an awake intubation. When we perform these things, a lot of times, especially that awake intubation, that's where we're going to use a fiber optic scope to view the patient's vocal cords. We'll usually give them a little bit of a sedative, so they're still awake, but they're not completely out. And we'll use what's called a acetylcholine spray, which is a bit of a numbing spray that we can put down over those vocal cords to take some of that discomfort away. One thing that needs to be noted though is during induction and extubation, so during this induction phase, the patient's hearing can be very hypersensitive. You'll hear your anesthesiologist tell you that the patient's sense of hearing is the last to go and the first to come back. So loud noises, quick movements during induction can cause a stress reaction in the patient, which will affect blood pressure, it will affect breathing, it can affect our heart rate, all those things that we don't want to affect. So it is very important to keep loud noises to a minimum during both the induction and the emergence phases. All right, the maintenance phase begins once the patient's airway is established and secured, and it continues until the surgical procedure is done. Additional medications are given, either IV or inhaled, to keep the appropriate levels of anesthesia in place. Awareness under anesthesia is very rare, but it is an occurrence that has emerged lately as some more challenging problems with anesthesia practice. But it is good to know that dreams and fleeting perceptions of induction, so those patients may have kind of fleeting memories of induction or dreams that they have while they're asleep. Those are not indications of awareness. Those are just normal brain functions that will happen. Some patients don't demonstrate physiological responses to pain during surgery, which results in a direct recall of intraoperative events. That's where our anesthesia providers come in and are really watching that patient's brain waves and their physiological signs. But that is often how an awareness under anesthesia occurs, is that they don't have those responses to pain like other people would with a, tachycardia or increased breathing rates. So that is something that is kind of an ongoing problem that we're trying to solve with anesthesia. Okay, patients with a history of substance abuse and chronic pain patients are also at a greater risk for awareness. Obesity, emergent obstetric procedures, hemodynamically challenged patients, and cardiac surgery are also at risk for these. If they've got a history of substance abuse, a lot of times they are going to require more of our anesthetic medications because their body is used to having these kind of things in their system. Same with our chronic pain patients. A lot of them are on prescribed opioids, so their tolerance level is a lot higher. There are some prevention measures that can be taken for this awareness, and that is the administration of midazolam, which causes amnesia, and the avoidance of neuromuscular blocking agents, if at all possible, will help us or help the anesthesia provider kind of pick up on those physiological triggers for pain. And there is an Insight 15.4 on page 210 that kind of goes over awareness in anesthesia. It's a pretty interesting read. Okay, in maintenance, we also have muscle relaxation. These are usually short acting and they're given during intubation. The long-acting ones are given during maintenance, and the peripheral nerve stimulator, which we talked about in chapter 14, is used kind of as a guidance device. So periodically throughout the procedure, our ACPs will check their facial nerves for response to that stimulator, and that kind of gives them a little bit of guidance as to how much medications may need to be given yet. I thought this was good. A surgical guide to anesthesia crisis. Is your anesthesia standing up? Something's wrong. Are they sitting down? Everything's sweet. All right, next we have our emergence phase. This is when the anesthesia agents are discontinued and they're allowed to wear off. Again, just as in induction, with emergence, loud noises should be avoided during this time. A lot of times during our emergent phase, because we're thinking of turnover and our next case and getting the next patient into the room, especially as surgical technologists, we are usually during this time, we're at the back table, we're cleaning up, we're putting our instruments away, we're throwing things out. And our instruments are metal, our tables are metal, they make loud noises. You can still clean up your case and get ready and start that turnover process. Just make sure that you're taking care to try and keep your noise levels down as much as possible. Okay, appropriate care is taken to time the removal of the ET tube, which is called extubation. The patients need to be breathing on their own with their airway reflexes in place. They need to demonstrate sufficient muscle strength to be able to maintain their airway independently. And an O2 mask is placed once vital signs are stable. Then the patient is taken to the PACU. All right, we'll go into some agents that are used for general anesthesia now. Our IV induction agents, these are administered to produce rapid loss of consciousness. They are classified as either sedatives or hypnotics. Benzodiazepines are preoperatively used more than they are intraoperatively. That is because of the high doses that are required to induce an unconscious state. So our benzos we're usually going to administer in the pre-op stage just to get that, that edge off for the patients. Okay, midazolam is administered for induction, but it does cause a greater drop in blood pressure than the diazepam. So we need to, another thing that the anesthesia care providers are aware of. Fentanyl may be given 3 minutes before midazolam to speed up the onset of the unconsciousness. And we need to note as well that benzodiazepines do not provide analgesia or pain control. All right, our barbiturates, also known as Brevitol, that's one that you'll need to know, Brevitol are barbiturates. Try and remember that as B and B, they go together, barbiturates and Brevitol. They are ultra-short hypnotic agents, ultra-short acting rather. Before propofol, most frequently these were the induction agents that were used, including thiopental and methylhexatol. Thiopental takes only a few seconds to travel from the injection site to the brain, but it also is very rapidly eliminated. Methylhexatol is often used for procedures that take place out of the operating room, like cardioversions. So think more procedures rather than surgeries for methylhexatol. These are both alkaline, and they do cause precipitation when administered with acidic agents. They both produce amnesia, but no analgesia as well. Patients that have had these tend to wake up agitated and disoriented because that pain, they're feeling that pain, so they do wake up a little feisty. All right, next we have ketamine. The trade name there is Ketalar. This drug is best used for short duration procedures. So things like our skin grafts, those are great for Ketalar or ketamine. Okay, they're dissociative hypnotic. They're used for induction and general anesthesia. It's the only hypnotic that is an amnestic and an analgesic as well. So it does have some pain control to it as well. The onset is within 30 to 60 seconds. And what we mean by a dissociative hypnotic is that the patients maybe appear to be awake with their eyes open, and even maybe some movements that may be jerky or short-lived. But they are dissociated from their environment. They don't recall anything that's going on. And this does not produce skeletal muscle relaxation. So as we said, these patients that have this on board, they may move around as well because there is no skeletal muscle relaxation. All right, etomidate or amidate is a hypnotic agent that produces an unconscious state in less than a minute. It provides no analgesia and no muscle relaxant. This is often used for patients with compromised myocardial contractility, so their hearts are not beating and pumping correctly. It's a rapid onset and it has minimal effect on the blood pressure, so that makes it an excellent alternative to propofol and barbiturates. This is also ideal for brief procedures such as the cardioversion, and also for trauma patients that are coming in hypovolemic, meaning that their blood pressure is already low. This etomidate gives an excellent alternative to those other ones, as we don't want to mess with that blood pressure anymore. So trauma patients are an excellent candidate for this as well. All right, propofol, otherwise known as Diprivan, is a hypnotic agent that's not related to any other agent. This is the most commonly used agent for induction. It is injected IV with the unconscious state coming on within 1 minute. It does not provide analgesia or muscle relaxant. Strict aseptic technique needs to be used when handling propofol. There are no antimicrobial preservatives in propofol, so it can support the rapid growth of microbes. So we need to make sure that we are absolutely using aseptic technique when administering this. Okay, that being said, it is still the most commonly used induction agent. Okay, there are some potential adverse effects with this: hypotension, bradycardia, and apnea. And it is good to note that most patients will report as stinging at the IV site and administration. but it does go away within just a few seconds because they are asleep. All right, we'll talk a little bit about some analgesics. These are given during the maintenance phase of anesthesia to prevent any pain during surgery. Adequate pain control equals less anesthetic agents needed. So the anesthesia part or analgesic part is a very common denominator in maintenance. Okay, it's administered before anticipated pain stimulus for maximum effect. So we usually like to have these on board even before an incision is made. That is obviously the first pain stimulus that patient's going to feel. So we want these in place before we start that. Okay, an IV formula of acetaminophen and opioids is indicated for preemptive analgesia, so that's usually what they'll give before we make that incision. The combination may decrease the need for opioids during and after surgery as well if we have that combination on board. All right, so opioids are the most common analgesic agent administered for anesthesia. They are able to bind with the brain's natural receptor sites, which are the endorphins, initiating that pain suppression. So natural opioids are morphine and codeine. Those are our naturals. The morphine's onset is 15 to 30 seconds, with the peak onset in 15 to 30 minutes. And the duration for morphine is about 4 to 6 hours. Codeine is usually given post-op. That is available as Tylenol 3, and it is a combination of the two, of acetaminophen, and codeine. Okay, our synthetic opioids are fentanyl, alfentanil, sufentanil, and remifentanil. Fentanyl is about 100 times more potent than morphine. The onset is 30 seconds, the duration is 20 to 40 minutes, and it does provide analgesia plus some sedation. Okay, alfentanil is about a quarter of the potency of fentanyl, also a rapid onset, and its duration is 10 to 15 minutes. Then we have sufentanil, which is 5 to 10 times more potent than even fentanyl, but it is very rapidly cleared from the body for rapid recovery. The duration is about 20 to 45 minutes. And the remifentanil, this is the newest of the ultra short-acting opioids. Onset is 1 to 3 minutes, but the duration is only about 5 to 10 minutes. And there is a table that breaks this down very well and makes it very easy to understand. That's 15.1. That table is your opioid comparison list. It breaks those down for you. All right, moving on to our inhalation agents. These are gases or vaporized air, also called volatile anesthetics, which we have briefly talked about before. The first agents that we ever used were chloroform, ether, cyclopropane, and nitrous oxide. That's what N2O is. The only one still used today is the nitrous oxide. Ether and cyclopropane are explosive, and chloroform is toxic to the liver. So we are not using any of those anymore. In 1956, halothane was the first non-explosive agent to be introduced, and we've just gotten them better since then. So these are distributed in liquid form. They're packaged in bottles. They're poured into a vaporizer that's on the anesthesia machine, and then they're turned into a gas that can be inhaled either through a mask, an LMA, or an ET tube. These diffuse rapidly into the blood via the alveoli, and then they diffuse rapidly from the blood into the brain, which is the action site for these. They're eliminated from the body very rapidly as well via the liver, kidney, and lungs. There are some disadvantages to them, and that is the potential for cardiovascular depression, and there's also that lack of post-op analgesia. The most common in use today are our nitrous oxide, our isoflurane, desflurane, which is also known as suprane, and sevoflurane, which is known as Ultane. So over here, you'll see that desflurane or suprane. This is a very common one that is used, so I would take note of that name there. And over here is just an idea of what our anesthesia machine is going to look like. So here is our vaporizer port. There's a small little area right here where this tip will plug into, and that liquid will then empty into the machine to turn into gas. All right, and we have our suction. We have O2 flush. That's in case we need to give the patients a good old big bolus of O2. This is letting them know which gases are on and where they're set at, oxygen, nitrous, or whatever we have over here, usually our suprane. This is our bag arm where normally the green silicone bags would hang that we can ventilate the patient with, and so on and so forth. Our breathing circuits usually plug in right here. So. All right, now we're going to talk a bit about the neuromuscular blocking agents, but before that we'll do a little bit of a review on muscle physiology. So as we know, there's 3 types of muscle tissue: cardiac, smooth, and skeletal. And the neuromuscular junction is an area where the motor nerve axon is very near the muscle fiber. The space in between that axon and the muscle fiber, if you recall, is called a synapse. Okay, the neurotransmitter at that muscular joint is acetylcholine. So when acetylcholine is released from the axon, it jumps across that synapse and it binds to the receptor sites on the cell membrane. Okay, acetylcholine then causes a wave of depolarization to spread across the muscle fiber to those T-tubules. Those conduct the wave of depolarization into the muscle fibers, and as a result of that spreading wave, calcium gets released, and those calcium ions allow the contractile elements of the muscle, which are actin and myosin, to engage, and that's where we get our muscle contraction from. Okay, now to go back to the resting state, our acetylcholine diffuses away from the receptor sites, and it's broken down or recycled by an enzyme called acetylcholinesterase. Okay, calcium ions are then transported back to their sarcoplasmic reticulum for storage and later release. Depolarizing muscle tongue-tied. So our depolarizing muscle relaxants are going to act like acetylcholine. Okay, they're going to bind with receptor sites and they're going to initiate a contraction. Okay, those are measured by anesthesia. They're called fasciculations. They're just very small involuntary muscle twitches underneath the skin. All right, and the non-depolarizing muscle relaxants are going to act as ACH antagonists, meaning that they're going to act like that acetylcholinesterase. They're going to competitively block those receptor sites and prevent that acetylcholine from binding, which prevents their muscle contractions. Okay, so with that little quick review in place, there are 2 types of muscle relaxants, and they're classified according to their action on that motor end plate that we just talked about. So there's depolarizing. These are our succinylcholine, which is only depolarizing relaxant in use right now. The effects are noted within 30 to 60 seconds. The duration is 5 to 10 minutes. There is no antagonist available, so succinylcholine just needs to be allowed to wear off. There are some adverse effects that go along with sex. It's increased intracranial, intraocular, and intragastric pressure. And a lot of patients also report muscle soreness post-op. Also needs to be noted that succinylcholine, or you'll hear it called Sux, is a triggering agent for malignant hypothermia. Okay, there are several non-depolarizing agents available. They are categorized as long, intermediate, and short-acting. They prevent muscle contraction, as we said, by binding to those cholinergic receptors and preventing that ACH from binding to those sites. They do not cause fasciculations, and they may be used before sex to prevent them. Selection depends on onset, duration, and side effects. There are some adverse reactions with these non-depolarizing agents. That's hypotension, hypertension, tachy and bradycardia, and arrhythmias. So as you can see, there's a bit of a pattern there. Most of these adverse reactions are going to be in the cardiovascular area. And they can be reversed with neostigmine. Occasionally, the procedure may be concluded sooner than expected, and that's going to require the use of reversal agents. I think the most common that everyone probably has heard of before is naloxone, which is Narcan. So naloxone, nalmefene, and naltrexone are all going to be reversal agents for those opioids that we're putting on board. Flumazenil, or Mazicon, is our reversal agent for our benzos. Neostigmine, as we just talked about, is our non-depolarizing muscle relaxant reversal agent. And then we have endrophonium, which is also another non-depolarizing muscle relaxant. The most common ones from this list that we will hear most often in surgery are the naloxone, or Narcan, and neostigmine. Those are the most commonly used. All right, guys, that's it. You did it. Congratulations. We made it through anesthesia. We've got one more chapter to go tomorrow, and you have officially made it through pharmacology. All right, if you have any questions, leave them here, guys, and I will see you in just a little bit.